Hello everyone and welcome to today's Healthy Dialogue. I'm Cynthia Cliff and I'm the Director of Knowledge Transfer and Partnership Development in the Faculty of Health at QUT, and I'd really like to thank you all for joining us today for this Healthy Dialogue. We have two very interesting speakers who'll be actually having a dialogue. They'll be working as a conversation, and so we have Dr. Christina Malatzky. She's a feminist sociologist and qualitative researcher whose research focuses on the social and place-based dimensions of rural health workforce retention and critical interrogations of power and discourse in the fields of rural health and gender and health. She's convener of the Rural Issues Thematic Group of Australia's National Peak Association for Sociologists, the Australian Sociological Association, and Fellow of the Higher Education Academy. She's interested in the operations of power relations between rural health and healthcare and the cultures of health systems and services and gender relations in medicine and healthcare systems. So it should be really interesting. And she'll be in conversation with Dr. Naomi Stecklenburg, who is a research advocate in the School of Public Health and Social Work here at QUT. As such, she works closely with many of the researchers in public health and social work to produce and disseminate research with impact. She's a scholarly communication specialist whose focus is on the use of social media in the academy and the mainstreaming of complex knowledge for broad audiences. Their presentation today will work as a conversation, and they'll be talking and bringing to light some of the implications of doing gender within the medical field, especially its impact on combating gender-based violence. I'm really looking forward to hearing this conversation, and I'm sure that it's going to be very interesting. I imagine that it will raise questions as we're going along. And what we'd like to do is, if you have questions as we go, please pop them into the dialogue box. Just type them in and we'll keep an eye on them and collect them together and have another conversation, a broader conversation with all of you after the initial two-way conversation. So thank you very much for participating today, and we look forward to seeing your parts of the conversation as this conversation goes through.
Thanks, Cynthia. Well, I'm going to take you all to the movies to start with. So hold on to your seats. In the 2020 film, The Invisible Man, the main character, Cecilia, is stalked by her controlling and abusive ex-boyfriend, who has figured out a way to make himself invisible. Cecilia explains at one point in the film, "I don't know how he's done it. He's figured it out though. He's figured out a way to make himself invisible. He's not dead. I just can't see him. Please tell him to stop." Scientists and researchers around the globe are currently preoccupied with making more visible a virus that is stalking humans. However, there is a less Nobel Prize attracting silent killer among us. Now, I'm not going to draw the obvious metaphor here and suggest that the invisible killer is gender-based violence. That would be too easy for you. Much more work is needed, but thanks to decades of awareness raising and advocacy by feminists, we can now at least see an outline of how gender-based violence leads directly to the deaths of, just as an example, about 137 women a day globally by the hand of their partner. The perpetrator is not able to hide as easily anymore. We can see him. What I'm going to suggest here though, and this leads us to the work of our guest, is that the less conspicuous killer may be the social and cultural attitudes that support gender-based violence and indeed allow it to continue. In her current research, Dr. Christina Malatzky wants to make visible these invisible social and cultural forces in institutions. And she wants to do that particularly by looking at how systemic gender biases influence medical practice. As such, she's currently interviewing GPs in rural settings, often the very people the first to know about gender-based violence, as well as some of their patients. Her project, entitled Exploring the Implications of Institutional Cultural Ways of Doing Gender in Rural Medical Practice for Healthcare Delivery, a Sociological Analysis, therefore seeks to unpack some of the ways doing gender inhibits the delivery of quality healthcare. So, Christina, let's begin with the line from the film. He's not dead. I just can't see him. Please make him stop. Can you talk a little about this idea of doing gender and how it's often an invisible yet really, really powerful force?
Thanks for that, Naomi. Thanks for that introduction and for that question, because it really, I think, brings us into the heart of why I'm really interested in this general topic. So from a sociological perspective, that concept of doing gender was really developed by Candace West and also Don Zimmerman to help us to really understand gender as being a performance rather than sort of necessarily a fixed or innate kind of identity. So when sociologists and other sort of related scholars are talking about doing gender, what we're talking about is really the ways that we act, our behaviours, our ways of presenting ourselves are really informed by the social interactions that we are engaging with that take place within a broader sort of cultural context. So for us in our sort of particular cultural location, we have quite strong ideas about the particular qualities that we might assign to feminine subjects and that we might assign to masculine subjects. And I think that kind of feeds into that idea of the processes of gender as being invisible, because we often sort of refer to these as being sort of natural differences, if you like. So following this kind of conceptual idea of doing gender, what we're sort of referring to is, because we are all on some level aware of these ideas that we have about what might be considered sort of more masculine behavior or what might be considered or expected of a sort of more feminized subject. When we are interacting with people, we sort of follow those scripts, I guess, or we act in ways, or we present our ways in certain, we present ourselves in certain ways that allow us to be assigned to those sort of binary categories of either a feminine or a masculine type of subject. But we can also, I suppose, flip that a little bit and think about, if gender is a performance, we can actually, gender does become visible through that performance, through our actions and through the way that we present ourselves. Yeah.
So GPs themselves aren't oblivious to the forces that may be influencing their, well, they may be oblivious, but they're not inoculated against the forces that may be, to use a medical pun, that may be influencing their interactions. So can you talk a little bit about how this concept of doing gender might apply in a medical setting?
Yeah. So I think certainly historically, and I think still today, medicine is really quite a prestigious and in many sort of contexts quite an influential profession. But I think it's really important for us to recognise that those broader social relations within our broader environment, if you like, that are informing the way that differently gendered bodies are interacting with each other and the particular power dynamics involved in that are also mirrored within the institution of medicine. So something that I'm really wanting to highlight is the way that institutions like medicine can't be sort of taken as separate from those broader relations that we're embedded in. And I know ideas like clinical neutrality are quite dominant within the medical field, but it's really important to recognise that those relations can't just be somehow neutralised when we come into that medical practice. And those institutions can be reinforcing and reflecting some of those dynamics based on gender that are that really do have quite powerful implications in our lives. And when we're talking about something like gender-based violence, we can see that some of those ways of performing gender can be really harmful, both to individuals and to the societies that we are sort of situated within.
Yeah, I was thinking about that sort of, I don't want to say famed, but that attempt at neutrality and how in effect, perhaps what you're suggesting is that neutrality becomes a political statement in itself, and it contains kind of political implications that perhaps need to come to light in order for equality and equity to occur.
Absolutely. I think that idea of neutrality is a bit like, that idea of sameness, I suppose. It doesn't actually produce equity, but it reproduces inequity and inequality. And I guess I'd sort of draw attention to the way that, in our current context, we can sort of hear debates about, well, in terms of gender violence in medicine, we're making a lot of progress. Look at how many women we have entering that profession, and we're really, those dynamics are changing. And certainly in terms of women coming into medicine, we are at the point where we are seeing in many medical schools at least the same number of women, sometimes even more women than male identified subjects undertaking those degrees. But we need to recognise that just increasing the numbers of women in the profession hasn't necessarily changed those broader sort of cultural structures through which medicine is really practiced. So we're still seeing women experiencing gender discrimination in that profession. There's quite a substantial body of international research really documenting the kinds of discrimination and the kinds of ways that those ideas about gender are still informing women's careers and women's careers progression within medicine. So it's sort of thinking about those reactions as being that idea of neutrality and saying, we're making progress. And as actually some of my colleagues have highlighted, that idea of denial in that sense is actually being, a very powerful way of doing gender. Because when we say that there isn't really a problem here and we're making progress, it means that we don't need to sort of do anything substantial to address those issues.
Interesting. So coming back to gender-based violence, which is the kind of focus of your work, have you got any examples or stories of how doing gender may affect the kind of outcomes for people who perhaps go to their doctor and tell them in the first instance that they are experiencing violence?
I think we sort of, in a way, need to take a little bit of a step back from that and think about, I suppose, that examples of doing gender within medicine at that sort of at that core face. And I think sometimes when we can think about the patterns that we can identify within medical practice and what that means in a real context can help us think about some of those implications at that patient point. So we know at the moment that we have women being more likely to be in dual incomes than their male identified colleagues in those sort of nuclear families, and to be less likely to be working full time, but also still likely to be, or as likely to be, engaging in professional development as well. We also know that women GPs are more likely to spend longer times with their patients, and this is relating to those ideas that we have about femininity. And on a different project that I'm working on, if it's okay to sort of digress just a little bit, some work I'm doing with Alana Hume around the rural sexual health workforce and looking at GPs' role in that. In a rural context, we're seeing female GPs really being assigned that kind of sexual and reproductive health work, which can be seen as stigmatized and perhaps more dirty work, to use figures around that. And what we're finding is that sort of really time-consuming work that goes into that kind of care means that those female identified practitioners in those practices are actually, that's actually contributing to a pay disparity, because they're taking longer with their patients, they're not seeing as many patients. So we know that female GPs are more likely to see younger patients, more likely to take on new patients, and also to be managing patients experiencing issues like depression, which again takes a lot of time, like dealing with a gender-based violence situation. That takes a lot of time to unpack and to work with your patient in those kinds of contexts. So when we take those patterns that we can see within medical practice into that rural context, where we actually have fewer female GPs practicing rurally, and we're actually not being successful in retaining those practitioners in rural environments. And then we start to hear contestations about that aim of achieving a sort of gender balanced medical workforce, which certainly I think there's growing recognition internationally that that's a really valuable goal, I guess, to have in your workforce. And some of those contestations are around ideas about, well, if we bring a female GP into our practice, she's going to be working part-time. Is that really, is she really a real doctor? Is that really going to help us with our workload, or is it going to be contributing? So I think that those kinds of ideas, sorry, can you hear me? Or
Yeah.
Oh, sorry. Yeah, I think those kinds of ideas are, at play there, and that informs the kinds of relationships and the kinds of care that can be provided to patients in those contexts, or has certainly implications.
Definitely. Thanks for revealing that for us. That's interesting. It really shocked me to think that the kinds of discussions that you've just alluded to then would even be part of but anyway, I'm often shocked by things I hear, so it's a surprise. So can you tell me a bit about why rural communities particularly are important to looking at these issues that we've raised?
I think for me, it's really about the importance of context and understanding context. So across all of the work that I've done in rural health, which has spanned a lot of different dimensions and topics, what I've always been trying to do is to emphasize that importance of recognizing place context. And, there's a lot of complexity around rurality, and you probably won't believe me when I sort of tell you the hours of agony that go into responding to sort of a reviewer comment that's, how are you defining rurality in this paper? It's actually a really complex question to respond to, and it's rurality is a really relational, dynamic, and not easily definable concept. But what I'm wanting to get across is that place context really does matter, and we have a lot of research both in terms of looking at gender in medicine and looking at gender-based violence, but a lot of that research is either implicitly based in metro or has an assumption that we're dealing with a metropolitan type of context and condition and circumstance that goes with that. So I'm increasingly, in many of the different teams that I'm working in, both in terms of this project and other work that I'm doing in a rural health context, is really trying to challenge some of those metrocentric assumptions that we have in research, and to really highlight that we need to be understanding these experiences, these processes within the context in which they're occurring, and to really have that at the center of discussions around particular responses and strategies to combat them.
And so can you tell us a bit about the project itself? Maybe a bit of background. I think we've touched on a few of the key ideas around the project, but maybe something in terms of your methodology and why you chose it.
So as Cynthia sort of included in the introduction, I'm very firmly a qualitative researcher. But I really do want to acknowledge the really important work that my quantitative colleagues have done in this space, and even Naomi, in your introduction, drawing on some of those numbers and some of those statistics has been really powerful for us to really be able to advocate for action in this space, and to help, I think, the general community to kind of grapple and try to sort of understand the scale and the prevalence of what it is that we're facing. But my aim as a qualitative researcher is really to grapple with the messiness and the complexity and the richness of people's experiences, and to try and really deconstruct some of the meanings and practices behind those experiences. So I'm definitely using a qualitative methodology within this piece of research, and I've sort of drawn on some of the tenets actually from critical ethnography that are really focused on deconstructing and challenging processes that are maintaining injustice, which we can certainly see in this domain. But as you also mentioned in the introduction, primarily in terms of data collection or forms of data, I'm looking at interviewing. So both practitioners, either rurally located at the moment or have a very recent experience of practicing rurally, maybe metro-based at the moment, and also community members who have that experience of either disclosing or perhaps attempting to disclose their experiences of gender-based violence in those rural contexts. But oh, sorry, go on.
Okay. Can I ask you if there are any findings so far?
Yeah, so unfortunately, my data collection has come to a little bit of an abrupt halt under our current sort of situation, which is a little bit, not ideal, because it did take a while to sort of get through ethics, and it was really exciting to be sort of beginning data collection and having that underway. But I think, like many researchers, there isn't a great deal I can do about that, and I think particularly for this project and who it is I need to talk about, or who I need to talk to, I need to be sort of sensitive to the challenges that my participants are encountering at the moment. So in terms of that practitioner side, a lot of those rurally based practitioners are under significant stress when we talk about the maldistribution of the workforce. It's a serious issue in rural Australia, and of course community members who might want to share their experiences, it might be problematic for some of those participants now that we are sort of isolating at home, and may not necessarily be the best timing for that. But I can just speak very briefly, and I just want to be upfront that I haven't undertaken a comprehensive analysis of the data that has come in at this point. But what I can sort of just point to in terms of the interviews I've done with community members, I think particularly in those more remote communities, I've potentially underestimated the significance of medical practitioners, not just in terms of that clinical support, but actually having the spaces of rural health services for women to go to in those quite small communities. Issues around choice of practitioner has certainly come up in those conversations in terms of differently gendered practitioners. And again, with some of the interviews I've done with medical practitioners, I think we like to, coming back to that idea of denial, I think we do like to think of some of these gender ideas as being, quite old, and that we've made some progress now that we're in 2020. But I've really been struck with how ingrained and how enacted some of those gender ideas are within medicine, and certainly some of the concerns that raises for practitioners, particularly in smaller rural emergency situations when they have patients coming in with health issues that are, being stemmed from a situation of violence, and what kind of environment and what kind of interactions those patients are likely to have in those services. So certainly some really, really rich data coming out of that. Yeah.
Any examples come to mind of some of the ways you've been struck by the problematic perceptions?
I think so. I'm thinking of, I do have to be a little bit careful here. And I should also say this is a national study, so participants can come from anywhere in Australia. But just some of the quite explicit gender discrimination that women in medicine are encountering, in terms of even in situations where they may actually be the senior clinician and being treated by other clinicians who are male identified as being medical students in some situations, and those kinds of dynamics, and also feeling quite at a quandary in terms of being, at one hand, the person who some of the nursing staff, for example, might direct attention to. They want you to see that particular patient because they think you might be able to respond to that, and some frustration over that, but also that concern on the part of some of those clinicians about, well, do I really want my male colleague who's just spoken to me like that to be interacting with clients who I know are in those really vulnerable situations?
Yeah, really tricky, hey?
Mm.
Any predictions, perhaps based on some past work of things that you've got in mind here?
I'm not very good with predictions. I suppose it's because I don't work with sort of hypotheses and testing and those sorts of things. And particularly in this particular project, because it is very sort of exploratory, and what I'm trying to do is just to gain some understanding and some insight into some processes, and also an intersection that at the moment is not well examined. But I think my feeling is, certainly in terms of thinking about what's been found in existing research, is that in this project, I think I will be able to highlight some of those workforce tensions within rural medical practice and be able to, I think, contribute to some of those broader conversations happening about how to develop that rural medical workforce. And I do want to highlight that from a rural health perspective, medical practitioners remain very influential actors in rural health services. So I think in that way, I see these practitioners as being really critical, not only in terms of, you know, the support that they provide to patients, often being that first point of contact and often the only point of contact with the healthcare system, but also being in that kind of influential position to be able to challenge some of those gender ideas would have a really influential impact.
What is it that makes rural doctors so influential compared with their counterparts, do you think?
I think that's, well, I think they are probably still influential in an urban context. I think some of that is historical, and you know, a lot of rural communities have struggled to recruit and to remain and to sort of retain doctors, and I think that perception that it has to be, you know, there are particular, I suppose, kinds of care that a medical doctor, you know, is the only practitioner that can provide that kind of care. I think we are starting to see shifts with that in rural health services, looking at alternative models of service provision. But I think there's still a lot of attention given to that medical workforce as opposed to nursing and to allied health in particular, which is actually, when we look at male distribution, it's actually allied health professionals that are most needed. But I think medical practitioners remain that kind of influential, those kinds of influential figures, and a lot of rural health services really rely on medical practitioners to keep their services operational.
Interesting. Now I can see that we've got a few questions in the chat. So
do I open that, or you've got that? You
can open it by just pressing the chat.
Yeah. Okay.
We might work our way through those, and they might lead to some other sub-questions from people listening. And we also have the capacity to give people voice. It's so powerful. So as researchers, so if there's kind of a question that perhaps needs a bit more dialogue, Jamie can open the floor for people. So let's start with the first one. Do you want me to read that out?
Yeah, that'd be great. Thanks, Jamie.
So Heather's asked,
a little bit small on my screen.
Heather's saying that she agrees in terms of the issue of neutrality, and that it actually is a big problem when it comes to gender-based violence. So thanks for that input, Heather. Louise has asked, do you find that there are different attitudes towards gender-based violence between rural and urban GPs or medical professionals? So yeah, that's a great question. Are there any differences there?
It is a really good question, Louise. To my knowledge, at this point in time, particularly in the Australian context, there hasn't been a great deal of examination into some of those differences. So I don't know if I'm well placed to respond to that particular question, but I think I can talk to the way in which rural practitioners are, particularly those who've been in rural practice for a long time, are of course very conscious of some of the particular concerns that rural patients may have in disclosing those experiences. Often these issues can be known, particularly in quite small communities, so everyone might actually know what's going on. There are of course a lot more interrelational connections between people, which can sometimes be of concern. Yeah, I don't know if I can really respond too in depth with that, Louise, but I can certainly see what else I can find in response to that, and I'm happy to proceed that conversation.
Okay, and Judith's asking, I wonder if you've noticed an age difference with the GPs. Do younger doctors actually see this as more a part of their role? And are they perhaps a bit more aware of the issues around gender and violence?
Judith, the doctors I've spoken to so far have been, I would describe them as being sort of mid-career, and some of them in that more, I was going to say senior, but I don't mean senior necessarily as, you know, very old, but just certainly quite advanced in their careers. So I haven't actually at this point in time spoken to many of those younger doctors in that cohort. But that would certainly be an interesting dimension once you know, got a little bit more, been able to collect a little bit more data to think about some of those nuances, again, related to age. And there has been some discussion about the types of training that medical practitioners are, I suppose, exposed to, but it seems that in many cases that's more of a you know, an elected type of training rather than something that's necessarily heavily embedded within medical curricula at the moment. So that's also an interesting dimension to be thinking about.
And I wonder if it's training that female identifying practitioners are more likely to take up.
That's certainly, so as I say, I can't, because I'm speaking about such a small number of interviewees at the moment, but certainly that's been the case so far, that it's been female identified practitioners who have pursued those opportunities.
Interesting. So Heather's asked a question, do you think you are likely to find class-based discrimination intersecting with the gender and the racial discrimination in rural?
I think that will, while I said, you know, not into predictions, I think that will inevitably feature within this project, and certainly some of the experiences of women that I've spoken to who come from, I'm trying to think of a good, quite dominant families, for example, in rural communities versus those who might be struggling or not, or don't have that kind of high profile family name, to be thinking about the different ways that they have been, you know, the interactions that they have in those services with those practitioners. That will be interesting to explore. I do think that will come out.
And Heather's asked another question, which we might allow her to speak to. Jamie, can you unmute Heather Fraser, please?
Description.
Hey, Heather.
Hey.
Hi.
Could you please ask Christina your question about prescription meds, because I think it's an interesting one, and perhaps one that hasn't, definitely one that hasn't been touched on today.
I just remember in the 80s when I started working in women's refuges, and certainly into the 90s, there was a big habit of prescribing, you know, Valium, sleepers, antidepressants, a whole raft of prescription meds to women. And then in 2010, I did a study with some people who'd been on methadone program. It was about working alliances and so forth. And some of the women that I spoke to had been prescribed originally Valium like 20 or 20 more than 20 years before, in response to violence, their experience of violence. So I suppose what I know that there was then a big expose and there were criticisms of doing that. But given the advent of, sorry, it's a long question, isn't it?
Yeah,
it could have just been, you know, we could have stuck to the simple one, but, you know, given the use of, they're even talking about MDA for those of us who were feeling sad in the pandemic, you know, using that, and HDA drugs, you know, so I suppose what I'm saying is, are you finding that a go-to is to give women scripts to try and help them contain their anxiety and their depression, which they understandably feel from being violated?
Yeah. Heather, I have to be honest and say that hasn't actually come up so far, but I'm really interested in that. I wasn't aware of that that history to that. So I'll certainly see what I can sort of draw out in relation to that in interviews to come. But I guess for me that really frustratingly articulates that kind of individualistic response to these types of issues. And again, for me, putting that onus, or to me, doing that puts the onus on the individual to kind of manage what you've articulated are very, very valid feelings and responses to have in those situations. So I think for me, it's about what kinds of supports and what kinds of structures do these practitioners have to actually provide meaningful support to their patients that are sort of beyond those kinds of, I suppose that's an example of the medicalisation of these experiences. Mm-hmm.
Can I respond, or
yeah, I'm okay with you to respond.
Thanks. My memory of the history, and then I worked for supervised, sexual assault workers and so forth. And my memory is that as feminists, what we did was we really rejected the use of prescription and any kind of, it was the time of rape crisis centres rather than clinics for people to not biomedicalise their experience, which we were saying was very much a political experience. So since then, I think people like me and others have taken a more kind of mixed position and said, look, the use of meds can be helpful in certain circumstances. So it's not sort of an all or nothing position, but it is to say, are doctors, and you sort of in some ways need to ask them, because I don't think they'll offer it up. They won't necessarily think of it. You need to ask, sorry, you don't need to ask them, listen to me telling you. You could ask them, firstly, what's the demand for those kinds of drugs? Secondly, what's their likelihood of prescribing them or offering them? And if they do that, do they do it in conjunction with, say, a referral or a little card to DV Connect or something else? Or is that it? Because it's not just bad practice, it's actually quite dangerous to keep medicating victims who are in lockdown, who are going to, because that can subdue them and make it even more difficult to get help and to flee. Sometimes you need the adrenaline to get out. And if you're chocked up with drugs, that's much harder. So anyway, that's just an alleyway that you might want to be alert to.
Thank you, Heather. Certainly, I'll see if I can get those little prompting questions in the next series of interviews I do. And I think that's really important. I guess I'm thinking about, what you've just said in terms of the implications of those medications in a body that's experiencing trauma, and that has certainly come out with some of my participants in terms of those community members, really talking about the long-term health consequences for them having experienced that type of violence and the real toxicity that's actually built into the body and takes such a long time to release and to come to terms with that on a physiological level, what's happened to you.
And one last comment, I suppose, is just that sometimes it gets incorporated into future violence, so that then the perpetrator says, you're a junkie, you're Valium head, you're a... So it gets... Do you see how it can compound? And so that can be internalised by the women who think, well, I am that.
Yeah, absolutely.
So,
can see those patterns. Thanks, Heather.
Aaron has a comment. He said that he finds it interesting learning about the similarities with what happens in his country. He says that he comes from a patriarchal country that's robed in cultural issues. Aaron, so do we.
Yes.
And I think that's what this research is starting to reveal. And Louise has another thought. Do we know if rural GPs feel confident or well-resourced with where to refer clients to for experiencing gender-based violence? And she adds that we know, for example, that in rural Queensland, sometimes patients and clients experiencing mental health concerns are referred to emergency departments.
It's just the best place to go. Louise, so far, and again, I am talking about a very small sample. So far, I would say that the doctors I've spoken to have not felt particularly confident or particularly resourced, and some of them have talked about, I suppose, a sense of powerlessness in actually being able to offer anything that's genuinely useful to those patients in those situations. So yeah, but that's at this point in time, and it would be great to have another conversation when I've gotten sort of more through that data collection and been able to do some of that really careful analytical work to report back. Yeah.
And on that point, Christine, I know that we talked a little bit before about how this is in fact a pilot study, and you're really open to any feedback or suggestions from colleagues about, you know, for example, some of Heather's insights that
Absolutely
yield better results for this, but also can be incorporated into future research.
Yes. Yep. So this is definitely a pilot study, and I'm really hoping that some of the understandings and some of the insights that will be generated through this piece of work will really help me to build more of a research program really in rural health, looking at gender-based violence, looking at gender-related health issues. So I'm really, yeah, very much open to hearing people's ideas on that, because I think at the moment, particularly in the Australian context, there's been, when I look at the rural health literature, very limited engagement with these kinds of ideas, which is we certainly know in Australia and also in countries like the United States that gender-based violence is, you know, disproportionately affecting rurally located women. So I think it's a real area in need of deeper reflection. Yeah.
So I didn't want to do this because often it it's in absolute silence, but I just want to give anyone else who's got any questions an opportunity to either add them to the chat or put their hand up and actually ask them before we end up today.
I feel like I'm in one of my tutorials trying to get the last
Squeeze the last
yes.
paste. While we're waiting for that, Jenny, you can tell people what your handle is for Twitter in case they want to follow your amazing Twitter feed.
I'm a very novice tweeter. It's at SocioDoctor, and I don't know if there will be something that comes out after this. Perhaps we could include it in the.
Yeah, that's a good idea. Let people know how to keep following your research.
Yes.
Naomi and Christine, Michael Dunn has raised his hand.
Oh, sorry, I can't see the hand signal.
Oh, hi.
Hi, Michael.
Hi, it's really really interesting discussion. I just about around 10 years ago, we did a study in rural and urban Queensland. We were asking nurses. This was a survey, a quantitative survey, but we had some qualitative elements to it. We surveyed around 900 nurses about their experiences of reporting family violence, and particularly violence against children. And most of the nurses were in urban areas, but I think there was some hundreds in all over Queensland. And one of the themes that came up when many of the nurses, all of them, they were required to officially report violence against children. And what we found was, but quite a lot of the practitioners said that they had observed it, they'd seen it, but they hadn't reported it. And when they were asked why, in rural areas, the nurses were much more likely than others to say, well, they were fearful for the repercussions to themselves, because the perpetrators knew where they lived, and so they felt vulnerable. Is that you just mentioned before with the doctors feeling a little bit disempowered or not able to provide effective strategies and solutions for the women who are victims of violence? Do any of them mention that they are fearful about the repercussions for themselves?
I haven't necessarily at this point in time, Michael, had any practitioners say necessarily fearful for themselves, but certainly talking about, I suppose safety concerns more generally, and I'm purely giving this as an example here. So in situations where perhaps the perpetrator might be a local police officer, and you live in a really small community, it certainly raises, I think, safety concerns that are potentially different than some of the circumstances or some of the potential implications in a metropolitan type of context. There's certainly be those kinds of discussions, and I think an awareness of just how difficult it can be for women to escape those types of situations when they're living in very small communities where there are those kinds of relationships and not necessarily a great deal of other social supports in place either.
Thanks.
But that's a really interesting to hear about that survey. I'll have to look it up.
I can email you the paper.
Oh, that'd be great. Thanks, Michael.
And we do have a comment from Aaron here in the chat area. Did you want to do it, Naomi, or do it?
Yeah, that's fine. So Aaron suggested that perhaps it would be great to do a comparison between the global north and the south in terms of these issues, Christina, and comparing the experiences he suggests could inform a global response.
I think that's interesting on a number of fronts, and I'm going to draw on sort of a point that my colleague Kath Cosgrave is increasingly talking about. Kath does a lot of workforce retention research, and she's recently returned pre-COVID from Canada, looking at some of the different strategies there, and she's really pointed out how rural communities across the globe can actually have more in common with each other than their metropolitan counterparts. So I think that's a really interesting dimension to that. But also I think, sort of picking up on something you sort of said earlier, Naomi, in terms of we might have this perception that in communities here in Australia that we might not necessarily have such strong patriarchal views, but that's not necessarily the case. So perhaps some of that type of research can challenge some of the way that we might think about ourselves in relation to some of those international contexts as well, and highlight the prevalence of some of these issues in our own context.
Most definitely.
Yeah. Okay. Did you want to bring Aaron's actually is able to talk if you wanted to?
Sure.
Have him say something.
Yeah.
It's a bit faint for me, Aaron.
Can you hear me now?
Yes, that's much better.
Yeah, right. So, like I said, I popped in the chat. Very interesting research there, and obviously, like I said, I come from a background where there's huge oppression for women in all contexts. So it was very interesting to learn from that in terms of medical practitioners. I've worked with nurses, doctors in community projects, and you could see some of these issues which is highlighted coming. So just in terms of future research, having to it's you have a focus on Australia, on the US. These are first world countries. But if you're hoping to sort of build this into a program like you've mentioned, it would be also great to think of countries that are developing, so to speak. I imagine having to compare your findings, in the future with what happens. For instance, in my country, Nigeria, that's a big project, or maybe a country, maybe Kenya or somewhere where this is where the research shows that there's a lot of oppression going on. So just thinking in that light in the future, it will be a very interesting study to,
I agree, Aaron. I think that would be really interesting too. And I think also to see what kinds of strategies countries like Nigeria are implementing, and what countries like Australia and potentially the US could learn from that as well. Yeah, I think that would be really interesting.
Definitely. Yeah. Thanks, Christina.
Thank you, Aaron.
Okay. And we've got Louise Baldwin has raised her hand.
Yeah, thanks, Cynthia. Thanks, Christina, Naomi.
Thanks, Louise.
A terrific presentation. I really like the Q&A style. It's awesome. Just a general comment / question, I guess, just to kind of throw in the mix for our future thinking, is that it just strikes me listening that there's maybe even a broader research question which actually might also interest other researchers in our school and faculty, etc., around seeking early help from medical professionals in rural areas, because it seems to be quite similar, the things that you're talking about from gender-based violence to what we have previously found in terms of mental health promotion and prevention, is that people are reluctant to seek early help. And also from my previous work in cancer control, women and men, but women particularly, are less likely to seek cancer screening, particularly pap smears, breast screening, or any sort of early intervention from male GPs particularly. You know, they might, I remember one of the quotes from our qualitative work was, the doctor was coming round for dinner that night, so I wasn't going to go and have a pap smear with him during the day, you know. So it's a real issue that small communities, as well as trust, etc., for that early intervention of many health issues. So it might just be something more broadly that we could look at.
Yeah, really, I completely agree, Louise. I think there's lots of dimensions to that idea of sort of seeking help early, and some of those, I suppose, interrelational or interactional barriers, for want of a better word. But I think also, I guess I'm thinking about some research I've read in relation to mental health in men, and this idea that we have of, you know, rural men being really stoic and not necessarily you know, seeking help. But some of particularly more contemporary research around that is highlighting that actually we are seeing people seeking help, but once there's is actually the gap between once they've sought help and when actual support can be provided, where we're potentially losing people. So yeah, I think that's will be interesting for me, because it will come back into that discussion around workforce, particular models for care provision in rural communities that aren't necessarily sort of replications of those same models designed for metropolitan contexts, which are obviously so different to the environments in these rural communities, that we might need to do things differently.
Yeah, I think that sounds great. I'd be, well, more than happy to chat further, and with anyone else that's interested as well.
Thanks, Louise.
And Heather has also raised her hand.
Thanks again for your responses. It's been great. I was thinking about what Aaron was saying and thinking, I supervised a woman who did a PhD in Bangladesh about shelters, women's shelters, because Bangladeshi DV law only came in 2010. And they had like 6 shelters, like in millions of population, what have you. So there are lots of class-based issues there. But some of the things I'm thinking about is rural practitioners in Australia who are dealing with, say, refugee, migrant populations, of women who, for instance, see, I supervised another PhD about vaginal fistulas, especially in Kenya. So I'm just wondering about also their knowledge or appreciation of some of the sexual-based violence that can come through maternity services, that, you know, not just the FGM, it's also those other practices of forced marriage and et cetera. And I know that lots of communities members are still connected to their religious leaders and their other kind of cultural leaders, but I think more and more are using GPs as well, like people have done at priests in the past, you know, to actually disclose. So I wonder about the kind of suite of understandings of cross-cultural issues that women face. That's all.
I think that would be a really interesting idea to pursue, Heather. And I think there can be an assumption. This is just purely just based on my own experience in terms of interviewing some refugee members of the community in a particular rural regional sort of centre, and assumptions that we make about preferences around practitioners, and actually some women in particular not necessarily wanting to speak to doctors who come from their same cultural location, and issues around interpreters as well in that space, and actually how that doesn't necessarily facilitate that kind of conversation. And I'd say there would be varying, I suppose, understandings of those issues amongst our GP workforce at the moment anyway.
Thank you.
I think we're just about coming to the end of our allotted time. Did you have any closing comments that you wanted to make, Naomi and Christina?
I think we've covered everything, but Christina, do you have anything that you'd like to conclude with?
I would just like to conclude with thanking everyone and for being so generous in terms of, you know, inputting and sharing your ideas. It's certainly given me a lot to think about, and I think as Naomi and I were talking about earlier in the week, I personally find these kinds of situations quite nervous, and she encouraged me to think of it as being, you know, that opportunity to have a dialogue with colleagues that I wouldn't necessarily have an opportunity to have this kind of conversation with, and to build on these ideas. So I just want to thank everyone for contributing and making this a very valuable experience for me, and I hope that everyone else has gotten something out of it as well.
Thank you both. That's been an absolutely amazing dialogue. I think you've probably got a lifetime plus of research to do now.
Yes. I don't think academics ever retire, do we?
No. And I'd also like to thank the Faculty of Health for supporting this series.
Absolutely.
The people behind the scenes, especially Jamie there, who's hiding behind the QT Health engagement logo, who's been helping us with all the questions and conversations. And also Julia and AV Services and all the people. There's lots of people that make this happen. Starting from next week with Zoom, there are some new security requirements. And so when people register or accept the invitation to participate in the Healthy Dialogue, you will receive a separate email with a password in order to be able to attend. So please look out for that password in future. I hope that doesn't stifle our dialogue, but I doubt that it will. It's always so engaging. So thank you both very much, and thank you to all the attendees and everyone who asked really interesting questions and provided input. We're very grateful. Thank you. See you next week.
Thank you.
Thanks, Cynthia. Thanks, everyone.